Right. Well, thank you very much. So, I thought I would restrict myself a bit to things that I know more about than other things, which is about cell therapies for the brain rather than cell therapies in general, because obviously stem cell therapies cover a wide range of things, of which perhaps the most well known is in hematology, in blood circles with bone marrow transplants and such like, which I know very little about. So I was going to talk about cell therapies for the brain and what it means. And it might sound a bit science fiction, but actually is coming to clinic and is in clinical trials and has gained a lot of momentum in recent years. So I need to just move on a slide, if I can do that. So let me just try and shrink that down. There we go. So, I mean, when we think about how we could repair the brain with cells, I guess the first question one would have to ask yourself is, well, what diseases could you repair? Given there are so many different types of cells in the brain and there are so many cells, the idea that you could rebuild a brain and repair it by putting in a vast number of cells is perhaps a bit unrealistic. But I think there are a number of conditions where this is appropriate and where this has come to clinical trials. So the first of this is where you go after replacing a particular type of cell, which you know is integral to the disease process. So I'm going to talk really about Parkinson's disease today, because that's the thing where we've done the most work on it. But in Parkinson's disease, as I'll come on to say, there is a very specific loss of one type of cell. I mean, lots of cells are lost in Parkinson's disease, but there's one type of cell in particular we know is critical for the manifestations of the disease. And so if we could replace and repair that bit of the brain, we could, in theory, have a major impact on Parkinson's disease. So I think Parkinson's disease is a sort of condition where repairing the brain or treating the brain with a cell therapy is possible. The other is where you lose a particular type of cell, which might not be a nerve cell, which is in Parkinson's disease, but cells which are involved with insulation. So multiple sclerosis, where there is inflammation in the nervous system, removing the insulation of the nerves, the so-called myelin. And there's a whole series of rare inherited disorders where children don't make normal myelin because the cells which are supposed to be making them, the so-called oligodendrocytes and the oligodendrocyte precursor cells, are missing. So you could imagine that if I could put those cells back, I could repair that part of the brain. So there are specific diseases where I think you could actually use cells to repair critical pathologies. And then the other place where people have been interested in this is using cells not to replace a cell in terms of reconstructing and repairing bits of the brain, but use them as a sort of, if you like, a bit of a Trojan horse, where you inject in cells. So things like a type of cell called microglia, which you've engineered to contain an enzyme or something that's missing in the brain. So some of the inherited disorders of the brain, which are rare metabolic diseases, are due to enzyme deficiencies, which have profound effects in the brain. So if I could inject cells where I've engineered them to produce the normal enzyme, which is missing in the patient, then that might be able to arrest and stop the disease by replacing the thing that's lost. So these are the type of diseases which people have considered using with cell therapies. And so what I'm going to talk about is Parkinson's disease as an exemplar on how we can do this and how far the field has come since the first idea on approaching this, which was some probably now almost 40 years ago that people first started about doing this. So Parkinson's disease is a common disorder. So in the county of Cambridgeshire, we did a study a number of years ago now, and where we discovered that every 4 to 5 days, someone's diagnosed with Parkinson's disease. So by this time next week, there will be 1 to 2 patients who would have had a new diagnosis of Parkinson's disease in the county of Cambridgeshire. So this is a common disorder, which is well known by, I'm sure, all of you. Which is defined by this slow resting pill rolling tremor, stiffness and slowness of movement, stooped gait, lack of facial expression, quiet voice, and a slightly stuttering walk with an absence of arm swing. So this is a common disorder. So in the UK, about 130,000 people. Typically, you get it at the age of 70. Male to females, about 3 to 2, so slightly more common in men. And as I say, we have a new case in Cambridgeshire every 3 to 4 days. For our discussion today, the critical aspect of this is the pathology. So within the brain, I'm going to go for this one, which is my laser pointer. So in the brain, this is the bottom of your brain. This is called the brainstem. Your eyes sit about here. These are your cerebral hemispheres. This is the back of your brain. This is the front of your brain. And at the top of this stem, in a bit called the midbrain, you have two pigmented areas of brain, which are called the substantia nigra. And within that substantia nigra, you have about 400 to 500,000 cells which release a chemical called dopamine. And these cells project from here up into this structure called the striatum, and they release dopamine. And part of what that does is it allows you to move in the way that you do automatically without thinking, and initiates movements. And in Parkinson's disease, when you've lost about half of these cells, so about 200 to 250,000 of these dopamine cells, you get the first clinical features of Parkinson's disease, which are this resting tremor, slowness of movement, and stiffness. And that loss of those cells is associated with a particular pathology, which people have gone after with therapeutic agents. But for our discussion today, this raises the possibility, could I put back 250,000 dopamine cells to actually restore this system back to normal? Because, as I say, you have 500,000, but when you lose half of them, you get the first features of it. Ergo, if you have just over half of them, you don't seem to have any symptoms or problems relating to it. So this has become quite an attractive target for cell-based therapies, and we know it's likely to work in the sense that if we give people dopamine drugs, which have been around since the late 1960s, people in the early stage diseases can go completely back to normal. So it can have a dramatic clinical benefit on these patients. The problem with the oral medication, so this is drugs like Sinemet or Madapar, or drugs which directly stimulate dopamine like Ropinirole, for those who are familiar with it, is that whilst they are very effective in the early stages, over time their efficacy starts to wane. They produce their own side effects, and they have a lot of off-target problems for the patient. So whilst they prove that if you can replace dopamine, you can make a major difference to the patient, they solve a problem, but only for a short period of time before other problems emerge. And so people for many years have been trying to work out how we can better treat Parkinson's by restoring or replacing this dopamine pathway. And there are two major ways of doing that. One I'm not going to be talking about, which is trying to regrow that pathway. So can I put in some sort of fertilizer to regrow that system? An alternative is to say, why don't I just replace what's lost in Parkinson's with 250,000 new dopamine cells? So just simply accept that the system's dying, but put in a new bunch of cells to try and replace those that are lost. And that's what I'm going to be talking about pretty much for the rest of this talk. But the principles here you could apply for other diseases where you're trying to target a specific population of cells. So if I was talking about multiple sclerosis, I could say, how could we replace the lost myelin-producing cells of the brain? And the principles are essentially the same. So this work takes its origins from studies that started in the 1980s. And there it was shown in animal studies that if you knocked out the dopamine system in rats and mice and put in dopamine cells which replaced them, you could put that system back normal. They would survive and they could reinnovate the brain. So this then led to studies in the late 1980s, which ran through the 1990s, really till the turn of the century, which were very encouraging before things slightly derailed. And essentially what it showed was that if you took out the normal developing dopamine cells, so this was an area of huge ethical controversy, because the only way you can get the developing human dopamine cells to inject in to replace the ones lost in Parkinson's is to collect them from termination of pregnancies, so abortions. So in essence, a woman decides to end her pregnancy, the tissue is terminated, it's then collected by the team. The bit of the brain which contains the developing dopamine cells is dissected out, and then it's transplanted into the brains of people with Parkinson's. So that was the essential work that was done. We know these cells grow very well in the laboratory, so although the fetus is dead when it's expelled and collected, the cells can nevertheless still be grown because they're still viable. And in animal studies, it was shown that these cells could survive. And what it was shown in patients over a number of years is when it worked, it could work extremely well. So these are two patients who were transplanted in Sweden, which is where this was pioneered by Anders Björklund preclinically and Ulla Lindvall in the clinic. And I'm just going to take you through these graphs. So this is a thing called the Unified Parkinson's Rating Scale. So the higher you are on this scale, so up here, the worse you are. If you've got absolutely nothing wrong with you, you score about 0. And normally when you present, you have a score of about 20 to 30. So if we just take this patient here, this was a patient who, at the time they had their transplant of this human fetal dopamine cells, had had Parkinson's for 10 years. So they'd had Parkinson's for 10 years. They were on medication. And despite the medication, they still had moderately advanced disease. They then had a transplant in one side of the brain, and a couple of years later, they had a second transplant. And 5 years after they had the transplant, they had improved by about 50%. So their score now, 15 years into their illness, was similar to when they first presented to their doctor with the original diagnosis. For the next 10 to 15 years, this patient remained absolutely stable. So their Parkinson's did not progress. They came off all their medication. And if you looked at dopamine levels in the brain, they were back to normal at the site where you'd replace the cells. So this showed, firstly, that if you put human fetal dopamine cells into the brains of people with Parkinson's, they could survive. They could survive long term, by which I mean 10 to 15 years, and they could return the patient back to normal, and they could lose their dependency on the drugs which they normally took for their Parkinson's. And this was replicated in a second patient who was not quite so advanced, but you see exactly the same effect. They improved, they came off their medication, and that improvement was sustained, such that 30 years after they first presented with their Parkinson's, they looked as though they hadn't got Parkinson's disease. So this showed that when it worked very well. Obviously, I've selected patients where it's been shown to work very well. So it didn't work in every case, and I'll come back to that. But the other important piece of information which emerged was not only did the patients improve back to essentially normal, their dopamine levels in their brain when you scanned them went back to normal. In patients who subsequently died, so this was a patient in Sweden who had such a transplant of these human fetal dopamine cells on one side of the brain. They then died 24 years later from unrelated causes. They only had the transplant on one side of the brain, and on this side of the brain, they didn't have a transplant, and the brown is where the dopamine cells are living and the nerve fibers coming out of them. Absolutely nothing, as you'd expect, on the non-grafted side. And in the side where the cells have been put in a quarter of a century earlier, they had all survived, and they had sent out little fibers to connect with the host brain in a perfectly normal fashion. And this patient had had a similar response. It took them a few years. They came off all their medication, and their dopamine levels went back to normal. Furthermore, in this particular patient, he'd had a scan 15 years before he died, so about 10 years after the transplant had been put in. And what they showed in this patient was that when they stimulated the transplant with a drug which was amphetamine, which is well known, but it's not a standard treatment. It's obviously a drug of abuse, but in this it was used experimentally to stimulate dopamine release from the transplant. What they found was that when they stimulated this patient's transplant with amphetamine, it released dopamine just as the normal brain would. So what these studies shows was that if you took the developing dopamine cells out of an aborted fetus, human fetus, transplanted it to the brains of people with Parkinson's, in some cases you could return patients almost back to normal. You could see that on post-mortem those cells survived for a quarter of a century. Either disease did not kill those cells, and that the cells could release dopamine in a way that was similar to that which you'd see in the normal brain. So then the question is, well, why has this not become a standard of care? Why is it that we don't see lots of patients with Parkinson's having this treatment? And the reason was that there are these results were very variable. So in other studies that were done in other parts of the world, it was shown that this was the best result, but a lot of patients got no benefit from the transplant. The dopamine levels did not return to normal. Some patients developed side effects from the treatment where they developed some involuntary movements from it. And there were also, of course, major ethical problems, because the only way you could get this tissue was not from spontaneous abortions, but from women who elected to terminate their pregnancies. So in different parts of the world, that is not allowed. It's obviously tightly regulated wherever you are, but in certain other countries, it creates major discussions, and particularly so in the United States. So as a consequence, this whole program at the turn of the century had sort of reached a bit of a Rubicon, in that whilst it worked in some cases, the fact that it didn't work in all cases, that it was using an ethically contentious tissue, it was felt that actually this treatment had no benefit compared to some of the other innovations that were coming through in Parkinson's disease. So we tried to critically appraise the field, which ultimately led to a new trial, which we started here in Cambridge a number of years ago, which was an attempt to try and get a more consistent, better response using this particular approach. And so in this case, we tried to select patients who we thought would be optimal for it. We tried to standardize everything that we did, and we transplanted human fetal tissue into patients with Parkinson's disease. And what we found was that this was logistically not going to be possible, and I'll come back to that, which is why we've now moved on to stem cells. And secondly, there are a number of critical factors which perhaps we'd slightly underestimated going forward. And so essentially in this study, what we did was we took a whole group of people with Parkinson's, out of which a number were selected to have transplants of cells of human fetal origin. So exactly as I've been talking before, women who came to the ROSI for termination of pregnancies, we would collect their tissue. We would have to collect the tissue from at least 3 terminations where we could identify the dopamine cells, and then transplant that into the brain. And we did 8 patients here in Cambridge, and we did 3 patients in Lund in Sweden, who are the originators of this whole approach in a collaboration. And essentially what we found was we didn't find a dramatic response. So in this graph here, we followed the patients for 4 years before we actually grafted them with the fetal tissue. We then followed them for another 3 years after we put the tissue into their brain. The control arm here are people who came up and had exactly the same assessments and scans of their brains as people who'd had the transplant, but we hadn't put any cells in their brain. We hadn't done any pretend surgery or sham surgery, as they call it, where we pretend to put cells in. So they knew they hadn't had a transplant. We knew they hadn't had a transplant. And what you can see is they progress, as one would expect, slowly over this 7-year period. In contrast, the people who had a transplant did not get dramatically better, but clearly after we implanted dopamine cells into their brains, their rate of progression, which had copied that which you see with people who hadn't had a transplant, flattened. In other words, those patients seem to have been stabilized by the transplant whilst not being improved. And then we looked at a couple of other measures, and this is the amount of medication they take. And we found people who'd had the transplant ended up on less medication. And they also reported that less of their day was taken up with the tablets not working and then being rather slow and sluggish, so-called off. So all of this implied that what we'd managed to achieve with our transplant trial was that we had managed to achieve a partial response, which suggested that we hadn't put in enough cells. So despite collecting tissue from 3 aborted fetuses, it looked as though we hadn't put in enough cells, or enough cells had survived. And that was then shown when we did imaging of the brain to look to see what had happened when we put the cells in. So this is a rather complicated picture, but this is a thing called F-DOPA, which is a measure of dopamine in the living brain. And the putamen is the area which has the biggest loss of dopamine in the Parkinson's brain. So this was before they had the transplant, and this was after they had the transplant. And this black line are the people who did not have a transplant. And as one would predict, they got worse as the system continues to degenerate in the face of the disease. In contrast, the patients who had the transplant had improved, but this line up here is where you put people back to normal. So what we'd shown was that there was a slight improvement, which was clearly different to not having a transplant, but it clearly hadn't restored things back to normal. And what was also of interest is in the patients who had the transplant in the putamen, you could see that the dopamine levels had stabilized and improved a little bit, but this bit of the brain, which lies adjacent to it, called the caudate, had no transplant in, even in the grafted patients, and that continued to decline. So what this showed was that in the patients who we transplanted, there was a partial clinical response, and a partial improvement on their scans. And in this graphic, you can see here, so let me just orientate you. This is a thing called the caudate up here, and running down here should be the putamen. And this is looking at dopamine levels, and you can see in this patient that the tail here has disappeared, but post-transplant in this patient had a very good response. You can see that there's clearly a marked improvement in the signal around the site of grafting. Whereas in this second patient who had a poor clinical response to our cells, we had little surviving cells. All of this told us that when we tried to use human fetal tissue, independent of the ethics to do with it, using 3 fetuses to get the dopamine cells, to transplant them in the brain, to put back the normal number of dopamine cells was not effective enough. We got a partial response, which was shown both clinically and on imaging. So overall, there was no significant benefit in this trial. It was likely that we'd underdosed, and that was shown both clinically and on imaging. And this was going to be a major problem going forward, because if we couldn't solve how to put more cells in or get greater amounts of tissue, we were very limited. There were some issues about the device, which I'm not going to talk about. And to further reinforce this point, in the patients in this trial, which took us 3 years to execute, we grafted 11 patients, one of whom had a transplant on one side of their brain. So for the 21 transplants that we did, we had another 87 slots booked in theatre, a whole day surgical slot to transplant cells, which we could not do because we didn't have sufficient cells to put into their brain. So for every 1 transplant we did, we had another 4 that were cancelled because we had insufficient tissue. So if this was ever to be taken forward, the only way we can do this is to have a cell source which is more available, reliable, and to some extent which we can standardize, so we know that every patient gets the same implant, which is not something you can do with this, because each patient has their own private collection, if you like, of fetuses dissected and delivered into their brain. So as we were working our way through this trial, we decided and realized that the only future for this therapeutic was to actually develop a stem cell source for dopamine cells. We also realized that we would have to work together with other groups around the world who are doing similar work, both within Japan and North America, to see if we could learn from each other and try and make this viable for the population of patients by working together to solve this problem. And so this brings us on to stem cells, which of course is very topical. It's very exciting. It has huge potential for a large number of conditions, not just within the brain, but things like diabetes, heart disease, and such like. But essentially, just to sort of orientate you about what we mean by stem cells have this capacity to self-renew. So all of us at some point began our life as an embryonic stem cell. They can proliferate and make another copy of themselves. They can also then differentiate into different types of cells. And so all of us, and this is what I'm going to come on to talk about embryonic stem cells, all of us began life as an embryonic stem cell. So every single cell in our body derives from an embryonic stem cell. So they have this enormous capacity to differentiate into all the cell types within the body. And so as you're developing, the egg gets fertilized, it develops zygote. This is the very early embryo, the blastocyst. You then get this thing called gastrulation, turns into a fetus, and then into an adult. And obviously these stem cells, these embryonic stem cells, give rise to every cell in our body. And within our body, we still have stem cells which give rise to other populations of cells. So, for example, the liver turns over, the blood turns over, your skin turns over. So there are all types of cells that turn over, and you have stem cells in your body, but they tend to be restricted. So skin cells will turn into skin cells. They won't turn into blood cells. Bone marrow blood cells will turn into blood cells, but they won't turn into skin. So these are called organ-specific stem cells. And then the cells we're particularly interested in are these embryonic stem cells, which come out of this fertilized egg, which, as I say, are the cells that give rise to everything in your body. And these have become an area of huge interest as we can see the potential for these to not only study early development and disease, but actually to use them to repair damaged systems within the body. The idea being you take an embryonic stem cell, or nowadays you can take adult cells like skin cells and blood cells, which I was talking about earlier, and you can convince them to turn into something like an embryonic stem cell, and then you can turn them into the cell of your choice. So in theory, using this, you could have an endless supply of stem cells to make an endless supply of cells, which you could use to repair any system, in our case, repairing the brain in Parkinson's disease. Now, in order to do that, what you need to be able to do is you need to be able to persuade an embryonic stem cell, or a so-called induced pluripotent stem cell, but we're using embryonic stem cells for the moment, to become a dopamine cell. And when we began our trans-euro study with fetal dopamine cells, that was impossible. No one had worked out how you could turn a human stem cell into the dopamine cell of the type lost in Parkinson's disease. And then in 2011 and 2012, there was a group in New York who formed part of our G-Force PD group, Lorenz Studer and Vivian Tabar, who worked out how to do that at the same time as my good friend and colleague in Lund in Sweden, Agneta Kirkeby and Marlin Palmer, worked out how you could persuade a human embryonic stem cell to turn into the dopamine cell of the type lost in Parkinson's disease. So this suddenly made it possible that could we really standardize and work out how to do this to a clinical grade, and thereby take human stem cells, turn them into dopamine cells, and use them to treat people with Parkinson's disease. So in order to do this, you had to show that you could do it reliably, robustly, safely, and show efficacy in your animal models, and ideally show it in a way which made it economically viable so that people would invest in this, so that we could take it all the way to clinic and to market if it was shown to be successful. So Marlin and her team did a whole series of studies where they demonstrated that you could do this in a very reliable way. So these are the cells which are currently in our trial that I'll come on to talk about in a minute. So this, you could take 3 different batches of the cells, you could freeze these cells down and then wake them up. And whenever you took these cells and used a particular protocol to make the dopamine cells in this animal model, the animals got better. This was another cell line. This was another cell line. So whichever line you started with, you could reliably and reproducibly always get them to turn into dopamine cells, as is evident here. So this is a transplant. All of this brown is the growth out from this transplant, showing that these cells survive and they have functional effects, and you could do it in a reliable and reproducible way. And importantly, it was incredibly efficient. So starting with a simple 6-well plate, within just under or just over 2 weeks, you could make enough cells to treat 500 patients. So if I had 1,000 of these plates, I would have enough to treat 500,000 people within a 2.5-week manufacturing run, which means I could treat pretty much everyone in Europe who might be suitable for this. So this suddenly made it extremely attractive as a therapy that could be useful for lots of people with Parkinson's disease and which would be affordable. And so this work, which took place over the next decade and so, which I was involved with along with Marlin, showed that we could reliably and reproducibly make an embryonic stem cell into the dopamine cells of the type lost in Parkinson's disease. We could do it to the numbers that were needed. We could do it reliably. We could put it in the freezer so we could just get them out when we meet a patient, so we don't have problems of supply. It seems to be safe. It never turns into tumors. And so this seemed like an extremely valuable therapy, which we now felt we could take to a clinical trial. And so over the course of the last 10 or so years, we had to adapt it to the level that was needed to be used in patients, so-called GMP. We then had to test it to the levels required by the regulatory authorities, which is called GLP. And we had to manufacture the cells in a site where they're allowed to be made of the clinical quality, or can be made to the clinical quality, which was the Royal Free Hospital in London. And then we had to get permission. We had to partner with various different agencies. So these are all the regulatory agencies in orange. And then we were fortunate to have a relationship with Novo Nordisk, who are currently the wealthiest company in Europe, who were interested in taking this forward. We applied for a clinical trial towards the end of 2021. We got permission at the end of last year in Sweden, which is the MPA. We got permission from the UK at the beginning of this year. And our trial, which looks something like this, began last year. So in this, we have patients with moderately advanced Parkinson's disease. They then have a transplant into both sides of their brain of stem cell derived dopamine cells. This was the first patient. We waited a month to check it was safe. There were no problems, so we treated the second patient. We then wanted to wait 6 months to check there were no problems. There were no problems. We grafted a third patient, and then we treated a fourth patient. So far, 4 patients have now been transplanted, and we're about to start the next 4 patients this year to complete our trial of 8 patients. So this is the first ever study in Europe of patients with Parkinson's disease receiving a human stem cell derived dopamine cell to repair their brain. And the hope is, if this works in our trial, Novo Nordisk, developing a very similar cell line, will then roll out a second trial. And if it's successful, then within 5 to 10 years, this could become a standard of care for people with Parkinson's, if it's proven to be efficacious in a reliable, reproducible way and is safe. Now, we're not the only people who are doing this. So this is our trial here with Cambridge spent incorrectly. So we began last year. The 12 months data will be next year. So that will be finishing at the end of 2025. In New York, the group whose paper I showed you earlier, Vivian Tabar and Lorenz Studer, who were, again, with Marlin and Agneta, the first people to work out how to make dopamine cells, set up a company called Blue Rock. Blue Rock's owned by Bayer now. They started grafting people with Parkinson's with their embryonic stem cell dopamine cell. I'll present their data briefly. Their first patient was grafted in 2021. They did 12 patients through to 2022. Their final data was collected in 2023, the 1-year data, and they just released their 18-month data. So their trial is now coming to an end. In Japan, they used a similar approach, but instead of using embryonic stem cells, so stem cells derived from spare embryos, they reprogrammed patient cells, so-called induced pluripotent stem cells, which they discovered. Shinya Yamanaka discovered it in Kyoto, and this is where this trial is held. So they made iPS cells and dopamine cells. Their last patient, last visit, was at the end of last year, so we're expecting the results sometime this year. A group in the Mass General in Boston took a patient's own cells, which I'll talk about in a minute. So there are lots of companies working on this. So Bayer and Novo Nordisk are obviously big pharma. This is Sumitomo now. There's a company linked to this. There are trials in Japan. There are also 2 new companies which have just got permission to go forward for clinical trials. Aspen Neuroscience in California are looking to do a trial taking patients' own cells and converting them into stem cells and then dopamine cells. And a group in Arizona have set up a new company that's just received £82 million of investment to do this in other forms of Parkinson's disease. So this has suddenly become a major interest in pharma. So there are billions of dollars currently going into this on the belief that this will transform what we do in Parkinson's disease. And I'm just going to talk about the only published data on this which has come out. So this was a paper which appeared a number of years ago now in the New England Journal of Medicine. This was a patient who had Parkinson's disease. Their cells were taken, so I think it was their skin cells or blood cells. These cells were taken from them. They were then programmed into these so-called induced pluripotent stem cells, so cells that could turn into any type of cell, like embryonic stem cells. They were then converted into dopamine cells, so the patient's own cells were converted back into dopamine cells, which are then transplanted back into their brain. So when they used these in animal models, they could show that the cells survived and behaved in a way which you would expect. When they transplanted them into the patient's brain, however, they didn't see much in the change of dopamine signals, which I'd shown you earlier in some of the fetal dopamine cells. On this measure, which I've already shown you, which is the UPDRS, higher is worse, lower is better, there didn't seem to be a major impact of the transplant. But on this thing called PDQ-39, which is how the patient perceives their illness, they felt much better. The higher you are, the worse your quality of life, and they felt their quality of life had gone back to normal over 2 years. Now, quite why this patient felt they'd improved when their objective measures had not has been an area of discussion. It showed that this approach was safe. My own interpretation of this would be that these cells were suboptimal, probably didn't survive very well, and therefore you didn't see a major clinical improvement, which would fit in with the imaging and the clinical response. Blue Rock, who I've already mentioned, have not published their data, but they had this paper or this poster at a meeting last year. They took 12 patients with Parkinson's disease. They took embryonic stem cells and converted them into dopamine cells in exactly the same way as I've discussed how we did it. They transplanted them into their patients. They showed these orange blobs here are signals of change. So they saw that there was some improvement on their patient scanning, and that there was also some improvement on some of these clinical measures. It wasn't huge, but this was only 1 year after the patients were grafted, and they recently published their 18-month data showing that this procedure was safe, and that there was clear signs that those who had had the bigger dose of cells seemed to have something of a clinical response. So these studies, which are still in their early stages, have shown that basically you can take cells, stem cells, you can convert them into the cells that are lost in Parkinson's disease, you can transplant them into the brains of people with Parkinson's disease, that they appear to survive, that they appear to have some functional benefits, although it's currently unclear what size of effect it is. And importantly, from a regulatory point of view, and especially from the patient's perspective, they appear to be safe. So to conclude, I would say that cell therapy has been used for repairing the brain. I talked about it in Parkinson's disease. They've also been tried in stroke. They've also been tried in a condition called Huntington's disease. They've also been used in conditions like multiple sclerosis. They've also been used in inherited disorders of myelination, insulation in the brain, and they're being thought about and being used for people who have metabolic diseases. So these therapies are becoming more trialed in diseases of the brain. They will not be useful for all diseases of the brain. So a lot of people say these could be useful for Alzheimer's disease. I don't think they'll be useful for Alzheimer's disease, because the problem there is that you lose all sorts of cells all over the place. And so replacing them will be extremely difficult, because it's unclear which cell you need to replace. And if you don't know which cell to replace, manufacturing a cell becomes extremely difficult. So I don't think they will help all diseases, but I certainly think they could have a major impact on certain diseases. There is a huge amount of interest in this, and there are vast numbers of clinics around the globe that will sell you stem cells for any condition that you like. So there is a lot of hype around this, and sometimes trying to distill out what's true and what's promised is extremely difficult. The idea of doing this in Parkinson's disease is not a new one. It's been around for 40 years. But what's exciting is that this has now moved from something that's been done in the lab to something that's been done in the clinic, with a lot of pharma investment, such that if this was to work, it would quickly translate into a standard of care if it was shown to give major results without side effects. That's quite a big if, but I think we're on the cusp of seeing whether that's true or not. Many groups and companies are doing this around the world. So I think cell therapies for fixing the brains, whilst it was always regarded as somewhat science fiction a number of years ago, is now at a very exciting point in its history. So with that, I will finish, and I'm very happy to take any questions on this or anything else you would like to ask me about cell therapies, which I will endeavour to try and answer.